Hi everybody. So we're going to go to Germany, I guess. So hi Andre, how are you? I'll just
Good.
introduce Dr. Andre
Hello.
Smith.
How are
He's
you?
the senior interventionalist in Leipzig Medical Center. So I think he was kind enough to do the first live case to do the kickoff today. Good morning, Andre. I think good afternoon for you, I guess.
Yes, yeah. Yes, hello to everybody. And first of all, thanks very much to invite us to present here two cases today. With me is Axel Fischer, one of our Syrian interventionalists. Yeah, so thanks once again. And the title for that first case was Severely Calcified SFA. And I think we found a case which fits here to that topic. Let's go to the slides.
All right,
Can you see the slides?
yes, we can see the slides. Yeah, and we can hear you clearly.
Yeah, perfect. Okay, yeah, great, very good. So next slide, please. Conflict of interest slides. Yeah, and here. So a relatively young man, severe claudication right, walking capacity 100 meters, ABI you can see 0.599. And he had some treatment on the left groin, PTA stenting or left iliacs. He merely could walk 30 meters with his left leg. Now everything nice left, but still 100 meters on the right side. So I'm still not really happy. Some coronary artery disease, quite a smoker, hypertension, hyperlipoproteinemia. Yeah, next, this is an angiography which we have obtained during the treatment on the left side. Left looks a little bit strange, so you can see the patch plastic on the left groin with, I think, an 8 French sheath in that it's not a thrombus. And the left iliacs with stenting. On the right iliac, this is not a stenosis or occlusion, it's just some no contrast filling occasionally here. And now you can see on the right side, that's actually all we have. A long SFA total occlusion, a stump looking into the SFA, distal, still some disease on the distal SFA. But here, I think we have the impression already that it's quite calcified. Yeah, next slide, please. Yeah, so certainly, well, not certainly, but we feel better going crossover for these very relatively proximal SFA total occlusions. We want to try to get the wire through, subintimal, maybe interluminal, depends on the calcification. If necessary, retrograde approach additional. And then, yeah, in fact, I think it's that calcified that this can only be done with high crash resistive for stents. So therefore, thorough pre-dilatation is planned here, potentially DCBs, sirolimus-coated balloons maybe. Well, at the end, maybe we need this kind of crack and pave technique. We'll see. That all depends on how the wire goes through and how it behaves during treatment. Next slide shows you, yeah, we are currently doing quite a lot of cases with sirolimus-coated balloons. So far, it's the Magic Touch balloon, which we're using with this kind of, I would say, quite sophisticated technology with this sub-micron-sized particles with sirolimus in it. This is encapsulated into phospholipid carriers, and this is then pressed into the arterial wall, where during the pH variation, this carrier opens up and sirolimus is released into the arterial tissue. So a lot of diameters and length is available. And next slide shows you there's quite a big program ongoing here, trying studying the Magic Touch balloon. One of the interesting studies, I think, is, and we were also involved, and the inclusion is already closed. Hopefully in half a year we'll have some results. The Sirona trial, so comparing this sirolimus-coated balloon to a paclitaxel-coated balloon. So that will be interesting. Yeah, potentially we will need this kind of drug-coated balloons here to treat together with the superior stent. Yeah, let's go to the angio, and I can show you already. We just started here. Angio, yeah. So here crossover. And I think you can appreciate here already that calcification. Further down, I think, yeah, another angulation. So there's some kind of post-stenotic, maybe dilatation of the profunda. Here, some calcium distal. yeah, I think you can easily call this severe or maybe extreme calcification, and outflow, yeah, is okay actually. Not so bad, yeah. Not very brisk flow going down. Yeah, first thing, of course, is to go through and you can see once again the calcification. And of course, dilating this will be quite painful. And what we are then doing, actually, that's our standard. We give local anesthesia all over the length of the calcified CTO. You can do this under fluoro, very easy, but you can also, of course, do it on ultrasound if we can just quickly switch to the ultrasound machine.
I guess with that calcification, you can directly stick it.
Yeah, yeah. So here you can see if you do it in ultrasound, it actually also shows you how the lidocaine we are using here, 1%, is spreading longitudinally, and so that you know that for the next 3 centimeters proximal distal, you do not have to puncture once again. Next, yeah, we did this once again. So that's really quite nicely seen here. But during fluoro, that's, I think, also very precise to do, I must say. Can we switch back to the angio? Yeah, so this is, I think, so 3 centimeters of a stump of the SFA, then occluded. And we thought it's so calcified that it may be difficult to get the wire through or in. So this is just a 4 French Berenstein, but I thought maybe I need a 6 French guiding. But, and together with a stiff angle Terumo, but yeah, surprisingly, catheter stick nicely in here, and the wire also went in here. It looks like subintimal around. So that's actually no surprise for me that the wire will not stay in the center of the calcium, but go around it. Yeah, but at the end, I don't know exactly. I mean, here, this is very bulky, looks like eccentric plug here, but going further down, maybe it's partially also just circumferential calcium.
Yeah, looks like it's
Also in another angulation. Yeah, so then I think, I mean, if we try, I think, yeah, from above, we lost already the ability to, or it will be hard to try to stay in the center of that calcium. But I think we have a second chance to stay somewhere within the calcium if we go from retrograde in. So I would like to take that chance. It potentially may make treatment later on easier, maybe. Yeah. So therefore, before I go further down with the wire, I probably puncture first here and take the wire upwards. Yeah.
Okay.
I don't know what you would do, but yeah.
Okay, Andre, I think you all got it. And moderators, you guys have any questions? The panel.
Yes. Andre, this is Fabrizio speaking. Just a question. Why
Hello, Fabrizio.
Hi. Why in your initial plan you do not consider atherectomy? This is because you know from the beginning that you will be subintimal, or because it's a too long lesion?
Yeah. Yeah, that's a good question. I think both reasons are true. First of all, I think the chance that you're always intraluminal somehow is not that high. I've seen this already proximally. Wouldn't like to push through here with this stiff calcium, obviously stiff calcium, a atherectomy down, and yeah, it's I think also too long. So will be very cumbersome. Risk of embolizing is certainly increased. Ich brauche noch ein bisschen Betäubung, glaube ich. So therefore, no, this is not what I would primarily do. Would you do this, or?
Yeah, Andre, a question. Why are we getting, I know you said you wanted to because it's calcified, but you're still getting the access in a CTO area. You don't think the loop you created from the top can dissect the vessel down and re-enter? You think you will have difficulty?
It could, yes. It could, of course, you're right. Yeah, that's a good question. In fact, I also don't know whether it's would be actually also quite easy to just pass by this calcium and re-enter distal.
Yeah.
Also, I mean, potentially with the help of a retrograde approach. and just do ballooning, cracking, everything, and so on. But at the end, yeah, at the end, I think if I go subintimal, the risk that would be high that I need a wire band, crack everything. So this kind of crack and pave technique. If I have the chance to stay somehow interluminally, I could potentially do everything just with Supera. That is currently my idea.
Yeah. Anybody in the panel would do anything different, or you guys have any questions? Go on. Fine.
Is this mic on?
Rami?
I mean, these are just difficult cases no matter what you do. Crossing, passing wires is extremely challenging. Crossing catheters is going to be challenging. Ballooning is going to be challenging. Getting luminal gain is going to be challenging. I mean, I think at every step of this case, it's not going to be easy.
I see that, Andre, you got the axis there pretty nicely on angiography, and I think you used ultrasound.
I had to. No, actually, without ultrasound, just on fluoro here. I mean, so easy to see the artery. I gave some contrast only to see whether this is an open segment here. But you could see, I mean, bringing the needle in was already quite difficult. Because of this calcium, I had to twist and drill the needle here through the calcium to be able to get the needle in. Yeah, very calcified. So we're starting here with the sheathless approach, but no, I don't think it will really help and be successful. It's just an attempt to somehow stay interluminal.
So are you putting the sheath in, Andre, or are you just putting the dilator of the sheath in?
Actually, no sheath. I'm just taking here support catheter, and this is now here a quick cross 018 compatible quick cross catheter. 90 centimeter long, and here, I mean, it's somehow already here tends to go subintimal, maybe into a collateral here. No, I think we are wasting here our time. Just a moment.
I think it's worth giving it a shot. Andre, I think while you're working on it, can we go to our lectures and we'll join you after every lecture?
Yes.
We have? Perfect. I think you can enjoy the lectures too with all the stress you already have. So I think we'll go back to Germany. Hi, Andre.
Yeah, hi.
Yeah, we are back to destroy your piece. So
no,
you want to give us an update? I think we've been watching. I think you got excellent progress.
We have done some work, yeah. So yeah, we stopped here. So we saw very soon that from retrograde also no easy way here to somehow stay interluminal. So we just proceeded with taking the wire down. So you can see here that was actually not that difficult. And pushing down here.
Nicht bewegen, bitte.
Then we pre-dilated here with a 4 millimeter balloon. Here, actually, absolutely no pain. Proximal, a little bit of pain. We continued to give some more local there, and yeah, and then it was very easy here to get the wire through. Here's the snaring here of the wire. Of course, sometimes you need some, but you can see already the catheter is touching here the wire from retrograde. And at the end, after some attempts here, that was not so difficult. Yeah, so proximal, some more local. And then we ballooned everything here now with a 580. We didn't have the impression that it somehow broke the artery, but we had no flow after that. And I think this is also, I would say, a good reason to implant a wire band, because I expect here now a lot of mud, a lot of material which can embolize.
Right.
And a 7 by 250 wire band seems to be perfect here.
Perfect here. Okay.
To fit.
So I see that you still kept your wire externalized. I think probably because you wanted the
Yeah.
rail.
Yes. In fact, it was not easy to bring the wire bar down, although we pre-dilated with 5. We could only bring the wire down because, with additional pulling on that wire here.
Nice.
Yeah, this is not infrequent that we see this here, that this is a problem, and then this pull-through wire is so helpful, yeah. Yeah, that's where we are, and now we need to post-dilate this wire band 7 at least with 7 millimeter, and let's see how he tolerates it. If at some spot he is feeling some pain, we can still give some local.
Anyone from the panel have any thoughts?
You know, this is a great case, Karthik. It's something that you see in everyday practice. I mean, there's 2 things here. One, it's heavily calcified. I think we know that whether you're subintimal in your terms of your recanalization or intraluminal, the patency rates are not really affected. You get good patency rate either way. I think the other thing to do is also you got to make sure you protect that profunda, especially, you know, you're going to be stenting all the way at least up to the origin or a little bit above it. That's where the failure is really going to occur. And so that's an important point as well. And I think in patients that are this heavily calcified, you're most likely going to need dual access. I mean, sometimes you can get lucky and do subintimal from above, but if you looked at that distal cap, the shape of it was kind of like a pyramid, right? So that's a tough cap to re-enter. It's not that you can't do it, but these are all the things you want to think of when you're doing this. And remember that, you know, this is a patient, you want to protect that distal runoff, especially in a Rutherford 3, you know, lifestyle limiting claudicant. Obviously failed some level of exercise program and so forth. So this is a really good case, and Andre, of course, as always, showed how he does this so easily, or at least makes it look easy.
Yeah, I know, right? He makes us look back.
840 conquest.
Yeah, I agree. One other point here, just from a multidisciplinary standpoint, I like the fact that the SFA, the distal SFA is preserved. You got that nice collateral there, so if this fails, the patient goes back to what they were before. And if you get to the point where you are going to do a bypass, you can still do it above the knee. Yep. As you guys know, the patency changes significantly once you go below the knee joint. So,
right.
Yeah, Andre, he makes these cases look easy.
Brian, if you saw this same case in your office and the patient has vein, what would be your algorithm? Endo versus bypass, because if you have a vein.
You know, so even in this case, you know, I think, and you set me up on a good one here, and I think these are recorded too, so I'm sure I'm going to hear about this. But I still, in these patients, again, given my skill set and, you know, the patency rates that we get so far, I'll give the patient the option, let them know durability is going to be a potential issue, and that bypass is always there. But in this particular case, I likely would still, you know, based on what the patient chooses, I still would likely choose endovascular intervention here.
I think, Andre, I think you can keep working on dilating that that stent, and I think we'll go forward with the lectures and we'll come back to you. I think we'll go back to Germany. Andre, we're back.
Yeah. So here you can see what we have done in the meantime. We ballooned here now with the 7 millimeter wire band with a 740 balloon. But in fact had the impression that maybe, so it didn't really crack. Sometimes you can see balloon is opening and all of a sudden it makes a step and the balloon gets bigger. Then you know you have really, now you have no resistance anymore from the plug. So therefore, but not in that case. So we continued well with an 8 millimeter. We didn't film this. 8 millimeter, 8 by 40 high pressure balloon up to 45 atmospheres. It also didn't really crack it, but it opened, we think it opened it nicely. And we have never actually seen a real problem with a 1 millimeter oversized balloon non-compliant in a wire band. So 1 millimeter oversizing doesn't destroy the wire band. 2 millimeter could, yes.
Andre, so I have a question.
Thereafter,
sorry, go ahead.
No, you.
I just wanted to ask, like, I know you cracked it open. I know you said initially you didn't use any other ballooning because you wanted to directly stent it, and then I think expand it. But I think after this, we had a great IVUS talk from Brian. So you wanted to IVUS after this, or did you have a plan to IVUS?
Well, actually, in Germany, I mean, our experience with IVUS and use of IVUS is limited because of no reimbursement. No,
Brian,
so
cannot talk in Europe, man.
so we live without it, and we take into account the reference vessel diameter. So you see here distal, for example, the distal SFA. So at least a 7 millimeter we think should fit in, and then we balloon in the Viabahn with 7 or 8 millimeter. I mean, 8 millimeter for an SFA is big, isn't it?
Yes, very.
Only possible with local anesthesia. He doesn't feel anything with it, but otherwise not possible.
And I think I saw you
we
giving
skip
local
this step
anesthesia
with
before
IVUS.
you started ballooning.
Yeah.
Yeah, I saw that.
Yes, correct.
And I think your next step is more interesting. Would you explain why the next step you did, what you did?
Yeah, so why? So here you can see already the result here after post-dilating the Viabahn with 8 millimeter.
Which looks very good.
Already quite nice.
Yeah.
Yeah. And also here, injected a little early. Very good. But I mean, so far we nearly always relined them with superior stents. We don't, because I'm not sure. I mean, I didn't see this cracking, destroying the plug. So I still assume that there will be some recoil forces. And therefore, I personally don't believe that the Viabahn in this extreme calcium can stay, I mean, is resistive enough to this recoil forces. So therefore, no, we reline them with superior, although it looks nice.
So you used a 7.0 Viabahn and cracked it with an 8.0 balloon. What superior did you use?
Yeah, then, usually we take 6.5 then in. However, you can also, I mean, dare to take a 7 millimeter in. But in fact, then I really want to see the plug or the artery, so to say, rupture when I open the balloon. And I didn't observe this here, so I continued here with a 6.5. You can see, I mean, it fits nicely. And in fact, I had to push a little bit. And also for the implantation of the superior stent, I'm still very happy to have the pull-through wire, because that also helps to pack the superior. If you do not just push from above, but also occasionally pull on the other wire end to help to pack the stent into the artery. So here, I think with 7 millimeter superior, we would have had problems.
Okay, panel, anything?
Yeah, that's where we are.
And we have the final shots after the superior. I think you're waiting for the prime time.
Yeah, we need another superior.
Oh. Panel, any questions?
So
before?
now here, yeah, sure.
I think Rami, want to say something? Brian?
I think it's great. So far, so good. I'm actually curious how he's going to manage the distal thigh axis site.
6,520.
I think another question. I mean, I think I have a lot of questions. I look bad here, but lithotripsy. I have a question about shockwave and lithotripsy. I know you explained why you didn't want to use prepping the lesion, but did you want to try it? Anything would have changed? Like just putting would you have avoided supera? That's my question. If you use lithotripsy, would that change your way of dealing?
Yeah. Yeah. I don't know. I don't know. I mean, we have used lithotripsy in studies, and we have seen good results with subintimal passage. Not so inferior, I would say. Not always that successful. My idea is rather maybe I could skip the step of taking a Viabahn in.
Right.
So it may be a safer predilation. Not in that case, because here the implantation of the Viabahn was a different one. There was no flow and plug material.
Right.
But otherwise, yeah, maybe.
So I think by the time you go on to do the final shots, which I'm pretty sure it's going to look amazing, I think we're going to go on to our next talk. And we'll come back to you, Andre. Is that good?
Yeah, perfect.
Okay. Hey, Andre.
Yeah. Yeah, hi. Yeah, okay, so here we continued, and here you can see the second implantation of a superior stent. So we're not the stents are really abutting each other, and so no overlay, no taking the stent for some millimeters into the other one. Then we would have a triple layer. That's, I think, not necessary. You can see how we can push with the second superior, the last one, pack a little more even. So we implanted here the other stent. Yeah, and the result, I think, looks really nice.
Does.
Very nice, brisk flow. Yeah. Yeah, very fast, much faster than Profunda. Yeah. So then we continue, of course, to care about the area distal. So our plan was either to use atherectomy here now or just ballooning. Now we decided to take just the balloon in. The sheath is still in. So usually we just take the sheath out and press with a finger for 5 minutes. Here, since we want to balloon that anyway, we took the occasion of balloon inflation from inside to stop the bleeding. So take the wire out, take the wire down, balloon here. This is.
And you used a regular balloon or non-coated balloon or a drug-coated balloon?
No, that was exactly the sirolimus-coated Magic Touch balloon now, 700. Yeah.
Need to send
So
them, you need to send some to Mount Sinai, so we need to use it.
Yeah. So no slow flow, no embolization. Very happy about this. Yeah.
I think the result is beautiful. This is like a dream intervention for all of us. And you made it look extremely easy and make us all feel bad. But
well,
so panel,
well,
anything?
Thank you.
Fabrizio, anything?
I don't know, Andre, if maybe there was the possibility to start to deploy the distal supera a little bit lower, where there was a little bit of some plaques over there, just to prevent any recalling in the future.
Yeah, so we took the distal superior a little bit out of the wire band, but not completely close to the collateral. We thought, well, if we want to do, prevent here this plaque to stenose in the future, we would have to take the superior for 10 centimeters further down. So therefore, no, we thought now, intervention took some time, so therefore no atherectomy now, just drug-coated balloon and see if we have restenosis there. Still, we can do first atherectomy, DCB once again, and then see how it looks like, yeah.
So, yeah, Andre, I had a question. You said you wanted to prevent embolization when you wanted to, I think, crack it first. So my question was, you were a subintimal, right? Even then you were worried about embolization when you would balloon it?
Yeah. Yes. Of course, we had no flow. That could be that it was just pure recoil. But you never know. Of course, we could have done a pullback angiography or IVUS or so. But there's still risk if you come from both sides or only from one side that you somehow crack at some point the membrane, that you open the gate for some thrombotic material. So, yeah, no. If I plan to aggressively balloon, I think aggressive ballooning, big balloons, have a high risk of embolization, and therefore, this is also, if I see things like this, one of the reasons to continue first with wire band and then with the rest. I would say it's just safer.
Perfect. Any other questions? So I think it's a fantastic case. Thank you so much for kicking off our conference with such a fantastic, wonderful case. Congratulations, Andre. Really taking time. This is a masterclass intervention. So. Questions?